CNS-led chronic disease care management programs is our episode topic. My guest is Dr. Molly McClelland, professor in the College of Health Professions and CNS program clinical coordinator at the University of Detroit Mercy. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Molly, thank you so much for joining us today.
Thanks for having me.
Before we get into our episode topic, can you share a little bit about yourself with our listeners?
I've been a nurse for well over 30 years. I have a master's degree, and I am a certified clinical nurse specialist. I have a PhD in nursing, and I am a professor of nursing at the University of Detroit Mercy.
In Season 2, Episode 20, Mitzi Saunders, then president of the National Association of Clinical Nurse Specialists, discussed the role of the CNS and how nurse leaders can maximize their use in their organization. Now, one of Mitzi's successors, Rick Bassett, continued the discussion in Season 4 on how to better leverage CNSs for organizational success. We've also had a few other CNSs talk about their work for various patient populations, and today we're going to focus on chronic disease care management. Can you talk a little bit about the CNS role in the outpatient setting?
This is a very underserved area where the CNS role can maximize patient care, quality improvement, quality outcomes. And I recently conducted a study that verifies and confirms evidence about the significant impact of clinical nurse specialists in the outpatient setting managing chronic diseases. So there is a part of healthcare called care management. Almost every single state has it. It is heavily influenced by insurances. Insurances want their patients engaged in care management because what that does is the care management team works alongside of the physicians and the other providers to improve quality in the patient. And what that means is we, as the clinical nurse specialist, you head the team of other providers, including registered nurses, dietitians, social work, community workers, pharmacology. So there is a team of people dedicated to improving the quality in these patients who have chronic diseases. And almost everybody has a chronic disease. By the chronic diseases, type 2 diabetes, overweight, obesity, hypertension, hypercholesterolemia, asthma, all of these diseases that people have that are chronic. Most of those diseases are reversible. We know, and the insurance companies know, that these chronic diseases cost significant healthcare dollars. And they not only are expensive, but they're very hard on the patient. As patients have these chronic diseases longer and longer, their risk of negative health outcomes increases. By that, I mean their risk of heart attack, stroke, kidney failure, all those kinds of other things go on at the longer and the worse that chronic disease is. So what care management does, led by a competent clinical nurse specialist in the outpatient setting, you start addressing ways to reverse those diseases. So we work with patients on one, identifying what the disease is, what the cause of the disease is, and how to start reversing it. The reason the clinical nurse specialist is so important in this role is because the CNS has an understanding of advanced pathophysiology, advanced assessment, advanced pharmacology, and we have the ability to write prescription needed for medical devices if needed. I often will prescribe things like continuous glucose monitors that I'm sure everybody has seen now, the Freestyle Libre and the Dexicons, so that patients can start learning what their glucose is doing. So if I eat X, my sugar does Y, things like that. I write for a lot of the GLP-1s now for my patients who have overweight and obesity. And the GLP-1s now, and by that, the Wegovy, Zepbound, Mounjaro, Ozempic, all of those that people have heard about. I write for those medications and work with patients one-on-one. I assess patients in the office a lot, all day, every day. And I will work with patients and we work on education. Are they learning about their disease? How are they managing the disease? And how are they doing with things that require lifestyle changes, which is really difficult because it's usually the lifestyle that has created the chronic disease. People either have been too sedentary, they've been eating the wrong things, they've been drinking the wrong things, and that has led to many of these chronic diseases. Now, there are a lot of genetic components and other things that we assess, but as a clinical nurse specialist, I assess those patients. So the way that it works is the providers that I work with, the physicians, PAs, the NPs, who are seeing the patient in the acute setting, they will identify a patient who has a chronic disease. Then they refer it to me. And then in the outpatient setting, I will then start working with this patient. I will do a full assessment on the patient. And if I need to start consulting with other specialists, like a registered dietitian, or perhaps they have social determinants that are impacting their ability to get food or transportation, then I can reach out to my social workers or my community workers. And it's a team approach, but as the CNS, as the leader of that, we have the ability to work among the three spheres that we're trained in. We're working with the patient specifically. We are working with other members of the healthcare team. We are improving the system, and we are impacting that patient in the healthcare setting positively and improving quality and improving outcomes. In the study that I just did, we looked at, I think we had about 3,000 patients that were engaged in the care management program that I lead in an internal medicine office. Every single marker that we looked at, and we looked at their weight, their blood pressure, their A1C scores, their glucose levels, their cholesterol levels, every single marker was statistically significant to improve in the patients who were engaged with a clinical nurse specialist in this care management program in the outpatient setting. So that's what I do. I firmly believe in it. And I firmly believe the CNS is the best person to manage these outpatient care management programs because they've been trained to work across all three spheres. And unlike my colleagues, like family nurse practitioners, the nurse practitioners are focused predominantly on the acute care of the patient. The CNS, I can assess that patient, but then I can also move into these other areas, which is so important for improving health, especially in our patients who have chronic diseases.
Yeah, that kind of went into my next question, or what I was thinking about asking, which was, okay, kind of what you're describing in the outpatient setting to me sounds more like a nurse practitioner than a CNS. Can you talk a little bit more about the difference here in using a CNS in this role as opposed to a nurse practitioner?
The nurse practitioners and the physician assistants are trained in patient management, mostly in an acute or a chronic setting focused on the medical aspects of that patient. But if you think about most patients and most people, it's not just your blood pressure's high or your cholesterol's high, and let me give you this medication to help whatever that diagnosis is. And those providers are very good at making the diagnosis and then prescribing an intervention. That's what they're trained to do. We need them to do that. Patients need that. But those providers typically do not have the time to address all the other components of healthcare that are contributing to that diagnosis. Like I've just mentioned, if you've got high blood pressure, I can give you a medication for that blood pressure, and I can quickly say, oh, by the way, reduce your sodium. Next, because the providers are paid on how many patients they're seeing during the day, and the patients need the providers. So we're trying to get as many patients in to see the providers as we can in a timely fashion to make it economically feasible for an office to run. The providers have their fee for service is dictated by their insurance. The fee for service hasn't changed much in years and years. It's very difficult in healthcare to continue to make a living just by seeing patients. So many patients a day. It's not, especially in internal medicine. So the problem that we're seeing in internal medicine, which is where most of these chronic disease patients are showing up, they're not going to specialty offices. So one problem that we're seeing in healthcare, I know this is a little off topic, is that the medical students now are not choosing to go into internal medicine or primary care because the reimbursement rates are low and they have to work a lot harder and they get paid less. The specialists, dermatology, cardiology, all of the other allergies, the specialists, they get paid much more. So what we're seeing now is the primary care providers in internal medicines, they're retiring at much faster rates than medical students are coming into this specialty. The medical students now that are coming out of medical schools are choosing to go into the specialties. It's just, it's a no-brainer. It's a better lifestyle. You get paid better. So what we're seeing happening is the insurance companies have not increased reimbursement. And so typically it has been a fee for service. So a patient would come in, your insurance will usually pay for a physical exam. Once a year, they'll pay for a physical exam. And after that, if you come in for a cough, cold, or whatever, it's a fee for service. But it's not a lot. Like a patient will come in, it might be $30 or $40 for that visit. So they have to see a lot of patients just to make it economically viable for them to run their offices. And so we need them doing that. In the care management program, the people who have set these programs up have identified that patients need much more than a 15-minute visit. You can't accomplish all that needs to be accomplished in 15 minutes in a setting where I can check your blood pressure, find out your blood pressure is high, let's adjust your medications. That's what a nurse practitioner would do. And the nurse practitioner, they're brilliant, and they would say to the patient, make sure you're not eating sodium or try to increase your exercise within that 15 minutes time span. But if in that 15-minute time span, they can identify this patient has hypertension and they probably also have overweight or obesity or something, if they had an opportunity to say, but let me refer you to our care management program. Now in the care management program, now they can come see me and now I can start doing a much deeper dive. Why do they have overweight and obesity? And that one gets tricky because there's a lot of reasons people have overweight and obesity. And oftentimes it is emotional. And so we have to start digging deep, and it takes a minute. So you've got to have some time to do that deeper dive. You've got to have the ability to be able to prescribe. You've got to have the ability to reach out to other members of the healthcare team. And you've got to manage all of that behind the scenes. You're sending in the prior authorizations. You're sending the referral to the dietitian. And it is this, and insurance is paid for it. So the way that my services get paid for is I'll bill that. I can bill when I talk to a patient. I can bill when I see the patient. And it's different billing codes than what the nurse practitioners are doing. So it's a different approach to the same problem, but a much needed approach. We need the nurse practitioners to identify the initial problem. They'll make the initial diagnosis, and then they refer to the care management program to then really dive deep and help this patient improve their health. So in the care management program, the patient would get admitted or referred to my program. And then I had the opportunity to bring them back once a month. I get it back on the scale. Like, Mr. Smith, how are you doing? How did you do on that diet? How did you do on the exercise? How did you do taking those medications? How do you feel on the medications? What do we need to adjust? Do you want me to send another referral to dietitian or social work or whatever it is? And so the relationship with the care manager, CNS, and the patient becomes long-term and frequent instead of the acute, I need to see you for this problem right now. I think that's the biggest difference. We work collaboratively together. It's definitely not an either or. It's a very much a team approach, utilizing the skills and the roles of each discipline to improve the health of that patient.
And so, in that aspect, from like a functional structure perspective, is that CNS typically housed within the same medical practice as the provider that patient sees? So that you've got your internal medicine doc that's out in the community, and they're part of a medical group. In the medical group, they have their nurses, they have their NPs, they also have their CNS. Or is this an independent program typically nestled within the health system that they're referring over to that is not directly under the auspices of that medical practice?
It can go either way. What we have found in our internal medicine office, and ours is a practice of 4 physicians and 3 mid-level providers, 2 PAs and 1 nurse practitioner. The members of our team, the registered dietitian, the social work, the pharmacologist, the community health worker, and there's 1 nurse over there too. There's 1 nurse in our office and 1 nurse off-site. Those specialists that I just mentioned, they are off-site and we refer to them because their services are not needed as much as the CNS and the RN in the office. So what we do is we rent them or we contract with them for so many hours a month because they also work with other internal medicine offices within our community.
Okay.
Just because there's not enough, like not every single patient needs a dietitian, not every single patient, and you're not going to see the dietitian every single month or the social worker, the community, whatever. But what we have found is that having a CNS in the internal medicine office and an RN. So I work in the office 2 days a week seeing patients, and the RN that works with me is there the other 3 days. And what we've found works best is what is called a warm handoff. So the physicians or the mid-level providers will identify a chronic disease in a patient. They will identify that the patient is struggling or needs more assistance in dealing and managing this chronic disease. So then they will refer to us who are directly in the office, and they will do what's called a warm handoff. We find that this is a really good approach to getting patients engaged in the care management program because that patient trusts their doctor or their provider. And so if their provider says, hey, I would like to refer you and get you started with our care manager to really help with this problem. Then the patient, because they also already have this trusting relationship with their provider, they're much more likely to say, okay, yes, let me try that. And so then they get engaged in care management, and that's how that relationship starts.
You talked about a study earlier about the impact of your programs. Is there any other evidence out there demonstrating the health benefits to patients being engaged in CNS-led care management programs, specifically in the outpatient setting or for chronic diseases?
There was not a lot. There was not a lot.
So you're the foundational study.
That's why I did the study because,
Okay.
yeah, I did this
That kinda
because
makes sense.
first of all, there's not a lot of CNSs in the outpatient setting.
Okay.
Most clinical nurse specialists are working acutely in hospitals, and they are working within the systems. They are working to improve qualities in the inpatient setting. CNSs do a lot of, they will evaluate, are the fall rates high? Are the catheter rates high? And then they will address why are these quality measures not what we want them to be in the inpatient setting? So the CNS would identify, here's the problem, and then they figure out why is the problem, and then they figure out how we're going to fix this problem. And so that's a big component of what CNSs do is we improve quality. But I think the CNS rule, I am a bit of a unicorn out there because there's not a lot of clinical nurse specialists in the outpatient setting, but I really believe that this is one area where CNSs we need more of them because the programs already exist. Care management has been around for a while. And having a clinical nurse specialist who understands all three spheres, has the ability to assess, to prescribe, to improve health, and manage this kind of team, I think that is the best healthcare role to manage these kinds of programs. But yeah, I'm an anomaly. There's not a lot. What a lot of places are using nurse practitioners in this role, and that's fine. But NPs have not been trained in quality improvement and system improvement and things like that are necessary for this role. It's not that they can't learn it. They can certainly learn it, but it's just the CNS is trained for it. And that's their role. And I think they're the best ones to do that. And I think we need way more CNSs in the outpatient setting.
Well, so let's talk a little bit about that for a moment. I want to come back to the study, but at some point in time, on season 4, I was talking with Dr. Jim Ballinghoff, who's the chief nurse executive for the University of Pennsylvania Health System, Penn Medicine. And he was talking about his care models in the inpatient setting. And our conversation was around developing the middle manager. And I was asking around what type of resources do they have? Are we talking about a clinical educator? Are we talking about a clinical nurse specialist? And he said, I have a hard time finding CNSs. And so I'm needing to look others. He talked about the gap, why that there's not enough CNSs. But yet I hear the CNS community saying, use us here, use us there. So in my mind, it's almost as if there's a misnomer, as if there's an underemployment around it, and you got a bunch of CNSs sitting around doing nothing. That's not the case. They're few and far between. So why is there this disconnect there and that exists? Is it truly lack of knowledge, or what's going on in the job market for CNSs?
The consensus is that many people don't know what CNSs do.
Fair.
For some reason, and it's not like we're a new specialty. We're one of the 4. There's 4 advanced practice registered nurse roles, and we're one of them.
Nurse practitioner, nurse midwife, nurse anesthetist, and CNS.
Yep.
So,
Yeah. And we've been around for a hot minute, but for some reason, people don't know what we've been trained to do and what we're good at. Many healthcare systems don't use CNSs to the top of their scope, but there's a major healthcare system in Michigan that doesn't let CNSs prescribe. I don't know why. And so they're using their CNSs more as nurse educators, and they're just not using them to the top of their scope, which makes no sense. Like, why you would hire somebody who has all this knowledge and skill in their training, but yet have them working basically with one hand tied behind their back. So I think the situation is, for some reason, we're trying to figure this out at the national level. Why don't more people know what clinical nurse specialists do? Because they were around when the nurse practitioners were starting to form at the same time, but the nurse practitioner role just took off. And maybe that was because it was closely more shadowed, like what the primary care providers did, what the doctor did. Whereas the CNS did some of that patient assessment, patient intervention, diagnosing, but they also had these other areas that they were trained and educated in, but people just didn't know it. So one problem that the CNSs are having now is when they're getting into the inpatient setting, they're having to prove and demonstrate that they have been trained in physical assessment and prescribing hours. And it's a bit of a fight for them to get credentialed and privileged, and they have to prove their worth. We're working to change that, and I think that if more healthcare systems utilize CNSs to the top of their scope, they would easily start improving quality and outcomes. They'd get to magnet status. So it is definitely something that we are addressing within our organization as CNSs. The other problem is many of the CNS programs are closing. So because of lack of enrollment, and that's a situation that we are experiencing in academia altogether, that at all levels of academia, we are seeing a reduction in enrollment and things like that. So that's also maybe a contributor. Our program,
it makes sense if you think about it from a chicken and egg perspective of what comes first. If I'm the CNE, like Jim was saying, I can't find them. So why am I going to create a staffing model that's solely based on them? I need to focus on a more diverse model because I can't find them. You go to that
Yeah.
to the nursing program and say, "Why aren't you doing it?" Number one, health systems aren't hiring them either because they don't understand them or because
Yeah.
there's not enough of them to
Right.
develop that stable model. And when we create the program, we can't get people to enroll. What's the solution here?
Yeah. If I had the answer to that,
Be
we would have
retired.
solved the problem. Yeah, I retire.
Yeah. Okay.
Exactly. Because that's exactly it. It's a chicken and an egg. So, yeah, we are working to fix it. We are working to increase education, increase awareness of the CNS. Most of us clinical nurse specialists are trying to do things like do the studies, write the articles, disseminate, talk to anybody that we can about what we do and why we do it and why we're good at it. And
So let's
yeah,
circle
we're
back. Let's
trying.
circle back to that
Go ahead.
study for a little bit. Then is that published yet, or are you planning on getting it published?
It has been accepted by the Journal Quality of Healthcare Management. It's the effectiveness of the clinical nurse specialist in the outpatient setting to manage chronic disease. I can send you a copy.
Oh, awesome! Thank you.
Yeah.
Appreciate it. Can you talk a little bit about the economic benefit to the provider practice when you implement these CNS-led chronic disease care management modules? What's the benefit there?
The second study that I did that's currently under review looked at the cost benefit of having a CNS in the outpatient setting running these programs. Because like I talked about earlier, the providers now are under incredible financial constraints because of the payers and because of how they're getting reimbursed. And so they're having to find ways that are outside of fee for service because the fee for services aren't going up. And as a matter of fact, in a lot of cases, they're going down. And the insurances just dictate what they're going to pay when. The providers have no recourse. Unless they're independent, do like a concierge kind of service, the providers can't say to their patient, I'm going to charge you $100. But the patient has a certain insurance that the doctor accepts. And the insurance will say, I'm paying $20 for that visit. So the doctor's not dictating that. And so they had to come up with different financial models. Some of those are called alternative payment models or incentive programs. These care management programs are some of those incentive programs. Because what will happen is the insurance will say, I want X number of your patients to achieve an example, an A1C of under 7. And so we have to look at all of our diabetic patients that are in that practice. We have to look at all of the ones that have A1Cs over 7 and then work with them to get their A1Cs under 7 throughout that year. And if we do, we get an incentive bonus. And it's usually substantial. It's usually a substantial incentive bonus. So in order to get somebody's A1C under control, now we have to work with them to get their diet improved, to start getting them exercising if we need to get them on a GLP-1. So that's another reason that it is really beneficial for these outpatient settings to have clinical nurse specialists in them, because there's often a financial incentive to the practice if they can improve health and quality in their patients. And again, the CNS is the one to follow and manage all that. So it becomes financially beneficial for outpatient doctors to be involved in care management programs.
We've covered a lot. Any closing thoughts as we wrap up this episode?
I really want to advance CNS in the outpatient setting. I want to get the word out there. I think that it's really important to have physicians and providers understand what the impact of CNS is running these care management programs. It's cost effective.
CNS-led chronic disease care management programs has been our episode topic. Molly McClelland, thank you so much for your time today.
Thanks for having me.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.